aortic stenosis. Aortic stenosis in someone who is hypertensive, a history of hypertension, blood pressure towards 180/80. Yes, the blood pressure was 180/80. You can write because it is so important. BP 180/80. So this is a case of aortic stenosis. The patient was 95 years. That is important because we have to get, if there is any disease, any valvular lesion, we have to get the cause, the etiology. We must find out. So this was a patient, 95 years old, non-hypertensive and diabetes. Diabetic. So the patient came with symptoms of headache and dizziness and easy fatigability. That's what she had, and chest pain. The patient had chest pain, headache, dizziness and easy fatigability. So we took the BP towards that one, 180/80. That is a wide pulse pressure. You know pulse pressure? Pulse pressure is systolic minus diastolic. So when you get systolic minus diastolic, that pulse pressure will be 100. That is pulse pressure. Pulse pressure is normally high in severe aortic regurgitation. Aortic regurgitation, if it's severe, pulse pressure may be high. But this one was stenosis. So she has two pressure overload pathologies, which is hypertension. We have volume overload and then pressure overload. Volume overload when there is regurgitation, and then pressure overload when there is stenosis. So this was pressure overload. Pressure overload, aortic stenosis gives pressure overload because it makes it hard for ejection. And then hypertension, also pressure overload. That is the pressure, systolic pressure in the aorta. So with those two pressure overload pathologies, we expect to find hypertrophy. Hypertrophy is of two types. We have eccentric hypertrophy and concentric. Concentric hypertrophy is when the cavity size narrows, reduces. That is, there is hypertrophy of the ventricular walls, like interventricular septum, and then the posterior wall. They become thick, but thickening going inside, taking away the ventricular cavity. That is concentric hypertrophy. Eccentric hypertrophy is when they thicken, but increasing the size of the ventricular cavity. So concentric hypertrophy is because of pressure overload, and then eccentric hypertrophy when do we need to increase the size of the cavity? When there is volume overload. So if the volume of blood supposed that it should be accommodated is much, then the ventricle will react by enlarging. So that one would be eccentric hypertrophy, where the walls may be of normal size or mildly increased, but the cavity size is big. So with these two pathologies here, we can expect concentric hypertrophy because they are pressure overload. Hypertension and aortic stenosis, they are pressure overload. So this is a Plaque's view. Before we are going to learn how to assess aortic stenosis, we are assessing aortic stenosis and grading its severity. Assessing and grading, because assessing itself is not much, but grading, it is the most important thing. The patient has those symptoms, you have to correlate Was it because of pressure or because of aortic stenosis? This was plaques. So next thing we are going to see if there is hypertrophy as usual. Regurgitation as usual first. We are checking. We apply color. Okay, before I apply the color, I have to take the measurements. Now, if you see here, this video combines everything. You see this thing from here up to here, it appears too big. We call this sigmoid septum. This part here, it is a sigmoid septum. It is very common in elderly people. So the septum becomes sigmoid. So when you are taking measurement, you don't measure sigmoid septum, because if you measure it, you'll find severe hypertrophy, which is not true. So sigmoid septum, when measuring, taking measurements by M mode, exclude it, and then measure after. You can ask any question. So this is sigmoid septum. We cannot measure from here. We cannot get the M mode line passing here, but this one we find when it is so hypertrophied. So we have to go away from it. So we went away from it. And then this one outlines properly the boundaries. And if you are to measure, you'll find when it is hypertrophied. See? Almost 2 point what? That is hypertrophy.
Measurement is 1.1. Measurement is
less than
1.1.
Yes. So this is hypertrophy, and if you check the cavity size here, 3.59. It is on the lower side. As
bears too.
Yes, it is on the lower side. These ones have not measured it because they are papillary muscles. Inside here, the papillary muscles and content, they are calcified. That's why they are bright. That is calcification. Go back to okay. Namukasa.
Can you edit it?
Namukasa. Open it. Thought it was like the other one I'm used to. Yes, so we have measured, we confirmed it is hypertrophy. And now, next,
regurgitation.
Next is check for whether there is regurgitation or not. This one we are trying to measure the left atrium, and the left atrium is just on a borderline. 41, that was in a borderline, but it's dilated, mild dilatation of the left atrium.
Due to regurgitation.
Not due to regurgitation, but it can be due causes of left atrial dilatation. 1, regurgitation if it's severe. Which regurgitation? No? Which regurgitation?
Left atrium.
Yes, which regurgitation? It can be there, true, because of regurgitation, but which regurgitation? Which valve?
Of the mitral.
Yes, mitral valve regurgitation if severe, or moderate to severe, it can cause left atrial dilatation. Another one that can cause left atrial dilatation is mitral stenosis.
Yes, mitral stenosis.
If not, you can have diastolic dysfunction. and another one is the dilated cardiomyopathy. They can cause mitral left atrial dilatation. Here, we don't see any part of any form of regurgitation here. We don't see at the aortic valve. We would expect blue to be coming this side, but we are not seeing. What we are seeing, it is a mosaic, different colors mixing, blue, red, and then part of yellowish. That is arising, indicating some velocity here is high.
Due to the stenosis.
There is turbulence.
Due to the stenosis.
There is turbulence. And then, if we go down on mitral, again nothing is clear. But when we go back, if we are to go back here, you see white on the valves, white, and then these ones are also so bright. These are calcifications. In an older person, 95, it is expected. We expect senile calcifications. You expect them, but the severity will always range. So if you see here, both the anterior leaflet and posterior leaflet, they are calcified. If you check here, they are calcified. So this one, even the conditendin and papillary muscles, they are affected. So severe calcification of the mitral apparatus is there. If we do short axis, you'll find the annulus is calcified, and we call that one mitral annular calcification. Mitral annular calcification is abbreviated as MAC. MSC. Then you can go on to grade it. This one we can just grade it because we are seeing everything is affected. The leaflet is affected, conditendin is affected, also papillary muscles are being attacked. So we can say it is severe calcification of mitral apparatus. Mitral apparatus contains mitral annulus, the leaflets, conditendin, and then papillary muscles. If you check the aortic valve, same thing. The leaflets are thickened and they barely open. You see, very small opening. Small opening is there. So if we confirm the stenosis, small narrowing, a small opening is there. We confirm this is stenosis. But now next thing, to grade it, because here we see it is stenosis. We put color, then we saw there was turbulence. Arising was there. Next is to grade it. But before we grade it, we have to go and do all other as usual. We have to do things as usual, checking for regurgitation or not. If it's stenosis, does it also have regurgitation? Chances here it doesn't have, only stenosis purely. Also mitral valve, it is stenosis purely, not stenosis as such. It is opening well, see? Is insignificant MS, we can say.
The left portion is slightly dilated.
It's slightly dilated, there are chances because of diastolic dysfunction. But this one is opening. If there is stenosis...
But couldn't the dilatation of the left atrium be due to the stenosis of the aortic valve?
Okay, how?
Since we are having left ventricular hypertrophy, then maybe it can't give room for dilatation, so there is that backflow pressure. We are having regurgitation at the LV.
No.
Okay. I rest my case.
It is not there. How? It is true stenosis of the aortic valve can cause dilatation of left atria.
Yes.
Because stenosis will cause hypertrophy, and the hypertrophy is a cause of diastolic dysfunction. Whenever diastolic dysfunction is there, it will be hard for the left atrium to empty blood into the LV.
Completely.
So
meaning
more blood will remain here.
Yes.
And after some time it will dilate. That is a pathophysiology.
Yes.
But here, MS can also, this MS is insignificant because you see the anterior leaflet is opening. So that MS, if it's there, it is insignificant. Here the aortic valve is barely opening. So we have to measure the right ventricle, Right ventricle measured. The cavity seems to be narrow, the LV cavity, but still maintain the shape. And this is mitral valve.
Short axis.
Short axis, but not clear. That is mitral valve. This is the aortic valve, barely open. We cannot do planimetry. If it was a very clear view, we could try to do planimetry, but it is not. So this is the fourth chamber, the left atrium, they are prominent. And this is the mark. Classification here. This valve chamber, it is not opening almost. The aortic valve and all that is calcified, severely calcified.
Dilatation here.
Severely calcified, the left ventricle is almost small. We said it's on the lower border, with narrow cavity. So next, we confirm there is no regurgitation.
Bad principle.
We are well read towards. So there is no, to be ready going this side, but no regurgitation at the aortic valve. Just restricted opening. Next. Now this is where now things are. AS. For AS, we know there is a stenosis, aortic stenosis. What is next is to grade its severity. Grading the aortic valve stenosis severity, we are looking at very many components. We are looking at velocities. We're going to look at maximum velocity, grading here, or severity of AS, we call it AS. Aortic stenosis. What we need to do, we take velocities. Velocity, where in there we have maximum velocity.
Vmax.
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 And then we have mean. Mean velocity. Another one we have pressure gradients. Pressure gradients. From pressure gradients, we have maximum gradient, PG max. Maximum PG. PG is pressure gradient. So PG, we look at the maximum PG. Right, maximum PG. Max PG. And then mean PG. Mean PG. Next thing, we look at aortic valve area. Valve area. Valve area. Another thing we are going to look at is the DVI, Doppler Velocity Index. Fourth. Doppler Velocity Index. Doppler Velocity Index. At least these four we are going to look at and how to do them. It may be a long video, we may not finish everything. But first thing is we've confirmed the valve is not opening very well. Next is to see how severe is it. We are going to do it by finding the velocities. The next, gradients. Next, valve area. Next, Doppler velocity index. But remember, we know pressure. Why do we need to know pressure at the time of examination? Because if the pressure is very high, systolic pressure is very high, it may affect our findings. So if you find it high, you know by the time of the study, the pressure was very high, if you find discrepancies, you can try to reason them out. So here, I was trying to find maximum velocity at aortic valve. Maximum velocity at aortic valve. But remember, this is Doppler principle. We are working with Doppler. We say it has to be as parallel to the direction of blood flow as possible. This patient had a sigmoid septum. You see it here.
Yes.
If I put my color, my Doppler line, scan line here, it is passing by through the sigmoid septum, meaning blood flow here it is blocked, and now it has to change direction going this side.
Yes.
Meaning this one is not parallel to direction of blood flow. So the velocity I'm going to get here, it is less. It is an underestimation of the velocity because of the sigmoid septum.
But we're using continuous wave, right?
Yes, continuous wave. We have confirmed there is aliasing, pulse wave cannot work. So first thing, we are dealing with velocity. Velocity is number one. Let's see. So velocity, we have to make sure that you are measuring maximum velocity. No underestimation. If there is chance of underestimation, then that's why it is recommended to take from multiple views.
So ideally, we're supposed to do pulse wave there.
No.
Do continuous wave.
Yes, because we are confirmed the velocities are high, aliasing was there. With the valve not opening well, we expect high velocities. Putting pulse, you won't say anything. So you have to use continuous. Continuous, but make sure you are measuring the maximum velocity. So this one, we have to dodge the sigmoid septum, the sigmoid part of the septum, and make sure it is aligned very well. So this velocity is less. It's not the true velocity. So you have to check from multiple views, multiple windows, like 5-chamber apical. You can go to long axis, parasternal, long axis view, or apical, long axis, the 3-chamber view, and then to find out maximum velocity. Here I was confirming if there is no regurgitation on mitral, it is not there. There is no regurgitation on mitral. Everything you must come. If you are not sure in one view, you have to change
To another view.
Here, this is apical long axis, 3-chamber view, zoomed. Zoomed for measurement of LVOT. We shall come back on it. We zoomed for measuring LVOT. I'm confirming there is no regurgitation and the valve is not opening well. See the only orifice here it is. We'll go in that side. Here I try to dodge the sigmoid by organizing the image. I try to dodge, and this velocity, at least you see it is uniform. Uniform thickness. So if measured, now remember I gave PG and then maximum velocity. It is good to trace because other views will require when it is traced. So on tracing, these are the parameters I got. Vmax, they say it is 2.25, a bit less. Vmin, it is 1.55, a bit less. Maximum PG is 20, mean PG 11, VTI 53.8. So if we talk of velocity, what do we want for AV stenosis, or for grading severity of aortic valve stenosis? If this Vmax is more than 4, it is severe AS.
Vmax is more than 4.
Yeah, 4 meters per second.
If it's
more than 400 centimeters per second. It is severe AS. If it's less than 2.6 to 4, 2.6 to 4 around there, it is moderate. 2.6 to 1.5 something is mild. You say the valve is sclerosed. And this is 2.26. 2.25. It is not mild AS. It is not mild AS because aortic stenosis will have high velocities because of the narrow opening which is there. So blood will be just rushing, the pressure there will be high. So high velocity. So this one, it is not mild. It is in mild, it is even mild. 2.6 to 1.5. It is in the mild range.
But now why are you saying it is severe?
No, we are going to confirm because we are seeing by opening. It is literally not opening. But the velocities are less. So, according to this is mild AS. According to this measurement here, it is mild AS. Another one we have to look at maximum pressure gradient. If it is severe, we need more than 60 millimeters of mercury. This PG max where there is 20, we need above 60. 40 to 60, that is moderate.
Above 60?
20 to 4, above 60, it is severe.
20 to 40 is mild.
Mild. It is 20.
Below 20?
It is fine. It is 20, just at mild stage. So these two measurements, Vmax and then maximum pressure gradient, it gives mild form. But we saw by observation the valve was literally not opening. It was not opening. So there is no way these things can. But we have to confirm either we are seeing poorly or it is truly these ones are lying. So this one meaning there is no one parameter that should be used to grade. No single parameter should be used independently to grade. So this, the Vmax and then maximum pressure gradient, they have given us that one as this AS is mild.
But as per the anatomy,
so
it is.
We go to another parameter, that is tricuspid regurgitation, and it was in moderate form. It was mild to moderate. Regurgitation is mild to moderate. Severe mitral annular calcification. How many remaining? 33 or 44. This is TR, this is moderate TR. Measuring again. Most of the things are already found here side. We have seen, we traced and found that Vmax 2.25, maximum PG 40, 20, maximum PG was 20. So we said we can grade it based on maximum velocity and maximum pressure gradient. Mean was 11.
Yes.
For mean, if it's above 40, mean PG, if it's above 40, it is severe.
No, if it's above 60, it's severe.
No, that is maximum. We put mean and max.
Okay.
For maximum, if it's above 60, it is severe. But for mean, if it's above 40, it is severe. 20 to 40, mild or moderate. And then below 20, it is mild. Again, 11, it falls in the mild state.
That is for the mean.
Yeah, for the mean. So, by the 3, this AS is mild, which is mild AS. So the remaining one is valve area. Valve area. Yes. So valve area can be measured by two methods. Planimetry can measure. Planimetry, that is when you freeze the image and then trace. Okay, we call it planimetry. Or using equation of continuity. Using continuity equation. Planimetry, the image was not clear. We cannot do planimetry because planimetry requires when you can see borders very well. It requires a very clear image. So what we are going to use, equation of continuity to find the aortic valve area. Equation of continuity. What does it say? You still remember? You read it the other time.
That is in relation to Bernoulli's principle. Is it systolic volume?
In a system, in a hollow system, the volume.
In a closed
system. In a closed system, the volume of blood passing one point equals the volume of blood. Now I'm using blood because we are in the heart. The volume of a fluid passing one point equals the volume of fluid passing another point. If this is point 1 and this is point 2, the volume of blood passing here, it is the same as the one passing this point.
So stroke volume in
stroke volume passing the mitral valve
should be equal to stroke volume at the aortic.
Yes. Or for this stroke volume passing the LVOT should be equal to stroke volume passing the aortic valve. Should be equal.
Yes.
But how are we going to get the stroke volume? You can write continuity equation. How are we going to get the stroke volume? We are going to make so many assumptions. Assumption 1, the ventricular outflow tract, it is circular. It is a circle. If you cut it, if you get a cross section, you find the circle. It is circular in shape. But it's not true, it's not circular. Otherwise, these measurements can be taken very well using 3D. Because the heart is 3D. So if you have 3 dimension, you are seeing the opening like this. So you can, if not circular this in this form, then you can trace here, you know, it is not completely circle. But here it is 2D. We are going to assume that LVOT is circular. So if it is circular, we have to get its diameter.
Yes.
How to get the diameter? You can use the 5-chamber view or the long axis flux view or the 3-chamber view. So getting the diameter of LVOT, you see this is the aortic valve. This is the aortic root. These are the leaflets thickened. So this is the aortic root. So the LVOT is below the aortic root. They say at least 5 millimeters from the aortic root. You take the diameter of the left ventricular outflow tract. So we got the diameter as 1.75. 1.75. Write it. LVOT diameter. 1.75 centimeters. So we have the LVOT diameter. So to get, we measured the other side. We traced. I'm going to trace it for LVOT. We have this as the diameter. Now to get the stroke volume, we must have an area of LVOT diameter, like LVOT. We have the diameter, we have to get the area. We are trying to get anything like volume. That's whatever we want. Because we are looking at stroke volume. So if you have the diameter and you are looking for the area, what do we have? We assume it is a circle. Area of the circle equals
area is equal to pi r squared.
yes, pi r squared. You have the diameter, meaning it will be pi d squared over 4. And then you put in the equation, you get the area. Area, which area?
D over 4 squared.
Yes, we have squared the 2 also. So you get the area, you put in the equation, you get the area. We calculated our area the other time. Calculated our area. It was this one. 3.14. The area was 3.14, that is the pi, times 1.75 squared over 4, and area will come up. Actually, we didn't get the just the area. You can get it back area, no? You just put in the equation, leave it there. Leave it there. That is the area. You can put in the calculator and get the answer. That is the area of LVOT. To get stroke volume, we need to get something like distance. Oh, this is centimeters squared. If you multiply more by distance, then you get centimeters cubed, which is volume. So how are we going to get where are we going to get that another distance? Where are we going to get another distance? I remember I took it. I didn't save it. I did save it.
Where do we take the distance?
The distance we are going to get the VTI. LVOT
Yes.
VTI. And the LVOT VTI. LVOT VTI. I did save the clip, but we measured LVOT VTI. This is centimeter. LVOT VTI, we measured it towards 22.3. If you go back where we traced for aortic valve, there is something called VTI there. This side, we have VTI. You see?
Yes.
VTI is there. It is in distance. So we are going to do the same in a 5-chamber view. 5-chamber view at exactly where we measure the diameter. Or we measure the diameter, you also put the now pulse wave, because we know the LVOT, there is laminar flow. There is laminar flow in LVOT. So we are supposed to use pulse wave to record something like this for LVOT. And then after that we trace it and get something like this, VTI. We shall get all these ones, but what we want here is VTI. And we
volume.
Yes, we did that one, and whatever we got, the VTI we got was 22.3. So write it. LVOT VTI 22.3. LVOT area was it? LVOT area was this one. So LVOT stroke volume is going to equal LVOT VTI times LVOT area.
Yes.
Yeah? Yes. So LVOT VTI or times LVOT area. That is the stroke volume. Now we go on aortic valve. Aortic valve, we have the VTI. Aortic valve VTI is 53.8. Aortic valve VTI is 53.8. 53.8. What are we looking for? Aortic valve area. We don't know it, because that's what we are looking for.
Yes.
So aortic valve area is not known.
So stroke volume at LVOT
is equal
to stroke volume
through the aortic valve.
Aortic
Valve.
So at this side we have the stroke volume.
Yes, which is 3.14 times
3.14 times 1.75 squared over 4
equal aortic valve
times 22.3
yes.
is equal to stroke volume, which we don't know.
Aortic valve area.
Aortic valve area. This is aortic valve area times the VTI, which we know.
54.
So it is 3.14 times 1.75 squared over 4 times 22.3 is equal to aortic valve area times 53.8.
Yes. So you do the calculation and you find the answer will be aortic valve area 0.99.
So aortic valve area
This
is equal to
0.99 yes centimeters squared. So that is the aortic valve area. So normal aortic valve area is between 3 and 4 centimeters squared.
Normal
Between 3 and 4 centimeters squared.
3 to
4 centimeters squared. That is the normal valve area of the aortic valve or the aortic. For severe AS, we need an area less than 1. For severe AS, we need an area less than 1. If the area is less than 1, then that is severe aortic stenosis. If it is 1 to 1.5, 1 to 1.5, it is moderate, around moderate.
less than 1.5
around there.
to 1.5. These are centimeters,
Say squared, yeah. And then 1.5 to 3 is mild form.
1 point.
I don't remember the figures very well, but it is like that. Yeah? Up to 3 it is mild stenosis. Now here, by our reading, remember we said the valve area is giving a severe form. Valve area is giving a severe form of this stenosis because it is less than 1. But it is
But the velocity was giving us mild.
yes.
Valve area is giving severe.
Maximum PG was giving us mild.
Mild, yes.
Yes.
Then we are dealing with Doppler velocity index.
Doppler velocity index. Now, Doppler velocity index is going to equal to, this is a dimensionless index. It doesn't have units. You just get the LVOT VTI divided by aortic valve VTI. LVOT VTI divided by aortic valve VTI, it will give the DVI, Doppler velocity index. So we are going to use it to see where what it is giving us. LVOT VTI
divided by
aortic valve VTI.
aortic valve VTI.
Do you still remember we got the VTI?
I think it was a trace.
Yes, it is just tracing. Most of the things are tracing. But VTI, again, there's a calculation. So LVOT VTI was how many? 22 points. 22.3. Yeah. LVOT was 22.3 divided by
53.8.
Dimensionless index, no centimeters, nothing.
Some index, there are no units.
Yeah. So it is around 0.41. It's around 0.41. So now, what does it mean? How do we grade AS by DVI? If because we said stroke volume across the aortic valve should be equal to stroke volume and LVOT. Meaning if they are equal, VTI should be the same.
It should be 1.
1.
So we're having less.
So if it is more than 0.5, it is mild. It is mild AS. If it is more than 0.8, 0.9, 0.7.
If it is less than?
If it is more than 0.5, DVI more than 0.5, it is a mild form of AS.
If DVI
more than 0.5, mild.
greater than 0.5,
yes.
that is
mild.
mild.
Yes. If
normal should be equal to 1.
If it is a 0.4, 0.5 to 0.25.
Then 0.5 to
0.25 to 0.45, right? 0.25 to 0.5.
0.25 to 0.5, that is moderate.
Moderate. And then less than 0.25.
And then less than
0.25, it is severe. Less, it is severe.
Less than 0.25, it is
severe.
So first is telling us mild, next is telling us severe, last is telling us moderate. So now which is which? Don't we go with moderate?
Huh? Why? Why are you going with moderate?
It is the mean. It's the mean of
mean.
Now we go to mathematics. We do physics, we go to math.
It's the mean. So DVI is giving us 0.41, which is moderate. Valve area gave us 0.99, which is severe, but it's almost 1. Which one less than 1, it is severe. So it is also tending to moderate. What lied more? It is the maximum PG and maximum velocity. Now we go on. We have phenotypes of AS. We have phenotypes of AS. Of course, we have to give final diagnosis and severity. We have low flow, low gradient AS. Low flow.
We have what? Phenotypes,
Just they can say phenotypes. What AS can appear in those forms. Low flow, low gradient.
Phenotypes of
AS.
Aortic stenosis.
Low flow, low gradient AS.
Low flow,
low gradient AS with reduced ejection fraction. Ejection fraction. We have low flow, low gradient AS with preserved ejection fraction. Low flow, low gradient AS with preserved now. EF, ejection fraction, we call it EF. Low flow, low gradient AS, just put this columns and one.
Low flow,
low gradient AS with preserved ejection fraction.
Low gradient AS with preserved
ejection fraction. Yeah. And then 3 is paradoxical low flow. Paradoxical, paradoxically low flow. Paradoxically low flow.
Low flow.
Low gradient AS.
Low
gradient severe AS.
Low gradient severe AS.
Yes. Those ones. So here we have to ask ourselves: is it truly severe AS, or it is moderate or mild? Is it truly severe? Because severity is valve area. Is it truly like that, or it is low flow? When there is, if flow is less, for example, low ejection fraction.
What was the ejection fraction?
The ejection fraction was 73.
Which is normal.
It is normal, and even when you check the plaques, you see contractility is very good. That is pumping. So is it truly low flow?
For this case, ejection fraction is 73.
EF in this patient was 73, but we have those discrepancies. So next thing we have to ask ourselves, is it truly the area 0.99, or there is something making it less? Things that can make the valve not open very well.
Calcifications.
Yes, but ejection fraction, if it is less, there is no reason why the valve should open all that wide. So it may appear small because less blood is passing. There is no much blood to force it open. Yeah, but in this case, the EF was 73.
Meaning contractility was okay.
Contractility was okay, but remember the systolic pressure. When the systolic pressure is high, 180 is very high, higher chances flow will be less. When systolic pressure is very high, it will be hard for this ventricle, even if it works hard, it will be hard for it to put enough blood in the aortic valve.
But I think systolic pressure was high because we are having the LVO.
The patient is hypertensive.
Yes, LVH.
And this is uncontrolled blood pressure. So it is making it hard for the ventricle to
release blood.
Yes. So will the velocity be high under that circumstance?
Yes.
When it is hard for you to move out, can you move out with a lot of speed?
No.
So you may have a low speed when you're moving out because outside there is resistance. So that one can be one, explaining the low velocity.
What is the relationship between pressure and velocity?
If you are to move out, maybe there's another force coming from the other side and you are to move out of this room. Can you move out so fast?
No.
When someone is pushing you from the other side?
No.
Or you have to put efforts to move out. You move out slowly. Same thing here. If pressure in the aorta is very high,
that means velocity is slow.
Blood will be struggling to get out from the aortic valve. So it will be hard. So that velocity will be less. And that one, because of 180 systolic BP, it can explain the low velocity and low gradient. So meaning these ones.
So that means this low flow is in the velocity.
Yes, low flow. We are talking about velocity now. Velocity or ejection or stroke volume passing. Yeah. So this one, it is abnormally low. We cannot take it because of that one thing. But also in the elderly patients, they normally come with that thing. Low flow, paradoxical low flow. Low flow, low gradient AS with reduced ejection fraction. Number one, with phenotypes with reduced ejection fraction.
But the ejection fraction
was normal, meaning it is not that one.
So we are having here low velocity,
low flow, low gradient,
and then low
AS with the preserved ejection fraction. Low flow, low gradient AS with the preserved ejection fraction.
We end up going for two. Paradoxically low velocity,
paradoxically low flow, severe AS. Paradoxically low flow, low gradient, severe AS. Is it true that this AS is severe? We got one in the DVI was giving us moderate, and also the aortic valve area, which is 0.99, is almost to 1, which is close to moderate, and it has a lower end of severity. Of severe, so it is going more into moderate. So we may end up going for 2 low flow, low gradient AS with the reduced preserved ejection fraction, and not the paradoxical low flow. Paradoxical low flow, it means everything is okay.
What is the meaning of paradoxical?
Paradoxical, like you don't it is going the other way around, like you can't explain it. You can't explain it, but you find it. Paradox, you can't explain it. but you find it after confirming, going back. First thing, when you find such discrepancy, all the measurements, they are not tallying, they are not agreeing. You have to go back if you need to make mistakes, meaning it requires multiple measurements. You need multiple measurements. I did multiple measurements with this one, and this was the highest. Just that I didn't record the save all of them. But you have to go back and recheck yourself if you didn't make any mistake in measurements. In alignment, this person had the sigmoid septum.
Yes, which you have to escape.
You have to escape it. You have to make sure you escape it. So you see how we measured the LVOT diameter, and then how where you put your sample volume when you're taking the LVOT trace, Doppler what? Spectral Doppler, where you put the sample volume. Is it true that in the same place you measure the LVOT diameter? Because it's supposed to be in the same place. So all those ones are sources of errors.
That's why I told you before us reaching to phenotypes of A's, and we are going to consider the mean.
Not the mean, you don't just consider the mean.
You have to assess everything.
Yes, you have to assess everything. So there are things we can do to confirm whether, but this one, we confirm that one if at all there was low flow, low gradient A's, and we'll see how we can improve the flow. But here, we don't need. This is very easy. If you try to make the heart beat so fast and what, actually the patient may collapse. Okay? So we couldn't proceed to do that. Otherwise, there are drugs we can give the heart to pump so fast and see if we can increase the valve area. Because I told you, there is no reason if why the valve should open all that wide when the blood passing is less. If less blood is passing, the valve will open as late as this one. If blood passing is much, then the valve will open as wide. So in cases where we find that it just open like this, less, chances are there that either the ventricle is not putting a lot of blood, we can increase it. We can make the ventricle to try to push more blood by giving pharmacological what? Dobutamine, the drug. It makes the heart beat so strongly and what? And it can increase. And you find most of the time you find that the valve actually, when blood passing increases, the valve open. And you find which if it was 0.99, if you give the drug, you find it is now opening. It is now the valve area is around 1.3, 1.4.
You give Viagra.
So there you don't. It is no longer severe. It was not truly severe. There was something making it look severe. But in this one, to be on the safer side, the doctor said we give moderate. Said moderate. So we give moderate, and DVI is exonerating us. DVI is more accurate than this other stuff. Yeah. So next one, I will bring theory part.
Okay.
Most of the things we have seen but not written. So theory part I will bring with so many examples. That is how we assess AS. You confirm AS visually and by velocities, and now you grade it. This was degenerative valvular disease with a lot of calcification, severe calcification on the mitral valve and the aortic valve, but with no regurgitation. Otherwise, there are contraindications where this continuity equation we have used, where it cannot be used, where there is regurgitation. Like for example, if there was mitral regurgitation, that's why I used it, because there was no regurgitation. But if there was mitral regurgitation, I wouldn't have used it. Thank you.
Thank you so much.
Last week it was for seeing stenosis.